Hello, my name is Josh Segal. I'm a medical science liaison, and this is part 3 of DRIP, Innovation in Fluid Management. My only disclosures are I work for Baxter, and I'm a medical science liaison. Obviously, I get paid a salary through that. So today we're going to talk about objectives related to how dynamic assessments of fluid responsiveness can be used at the bedside. We're going to explore how dynamic assessments serve our patient population, especially our sepsis population. And then we're going to look at some technologies that we can use to look at fluid responsiveness and how the clinical application of particular protocols fit into our workflow. I also have a couple of patient examples that we're going to look at towards the end. So what is a fluid challenge? We've known for a while that an increase in stroke volume and cardiac output of at least 10% is considered a positive fluid challenge. This is where that 10% number kind of comes from. It's from this previous work from Sansoni. And then looking at an internal bolus or a passive leg raise, if we translocate volume from the lower extremities into the chest, can we use that as a reliable tool to use that as a fluid responsive test? It turns out we can. So there's two ways to do this. So the sensitivity and specificity of passive leg raising is actually quite good. We can also use a fluid bolus challenge. In both of these, we use one or the other to determine if a patient's fluid responsive, but it's also kind of really looking at is where the patient is on their Frank-Starling curve. So as a reminder, so preload along the x-axis, stroke volume along the y. So just like a rubber band, you pull the rubber band back and it snaps back. Where does the effort come out on the other side? So if we see a rise in the patient's forward flow or in stroke volume, we can say they are on the ascending part of their curve, and the patient is fluid responsive. If the patient's on the flat part of their curve, then you will get a marginally low or non-existent response out of their stroke volume. So for workflow, I can use this strategy not only in critical care areas, such as in the ED or the ICU, but anywhere the patient has a perfusion problem. So if they're on a general floor, if they're on a rapid response call in the OR, when I'm assessing a patient for volume, me as a clinician prefers that if this was the only reason to resolve this instability or issue for perfusion, I would much prefer to give you volume. So hypotension, poor urine output, patients on vasoactive drips, these are the primary targets to resolve with fluid responsiveness. But if it's looking like they're not fluid responsive, it can give us some guidance if the patient may need some vasopressors and perhaps looking at something more related to the cardiac. So I want to take a moment to look at severe sepsis and septic shock. So I'd like to take a moment to discuss sepsis because there are some recent changes and upcoming pieces of information I'd like to kind of review. Just as a reminder, Surviving Sepsis Campaign is a group of physicians and practitioners worldwide that get together, and every few years they come out with some recommendations that are evidence-based about what's current. They're hyper-focused on sepsis, and they give recommendations that's freely available. And one such entity that takes advantage of this is CMS, the Centers for Medicare and Medicaid. So as we all know, CMS provide measures for various different types of healthcare programs, one of which is the SEP1. And they use financial motivation to guide hospitals to sort of direct on what we should be doing. Just so you know, the timing updates between Surviving Sepsis Campaign and CMS may not always align. Surviving Sepsis Campaign gives their recommendations, and CMS may or may choose not to use them or come out with some on their own. But ultimately, when we're practicing at the bedside, CMS is probably the one that we're going to be focused on because it's tied to reimbursement, or at least it will be. For the endorsement of dynamic assessments, it's been coming along for quite some time, but in the past few years, there's been a really growth in professional organizations adopting the recommendation for fluid responsiveness. And there's one particularly of this year I'm going to cover here in just a moment. So this is from 2021. This is Surviving Sepsis Campaign guidelines. And there's something to point out here. Back in 2015, Surviving Sepsis campaign started releasing information on recommendations of guiding fluids with dynamic assessments of fluid responsiveness. In this 2021 update, they've actually increased their strength to now recommend against other indicators of fluid status, such as heart rate, systolic blood pressure, and CVP, in favor of dynamic measures, such as a passive leg raise or fluid challenge, because of their better diagnostic accuracy. I'd like to cover some perhaps underrated CMS changes that hit the HIQR in July of this year. This was version 5.14 that was actually had an update. Looking at specifically for the guidance of not giving crystalloid fluids in the early shock phase of sepsis. So the documentation of not fluid responsive can now be used as exclusion criteria if those measures were taken with either cardiac output index, stroke volume index. The word's getting out about the benefits of fluid management. So not only can fluid responsiveness be used to guide fluids during early sepsis and septic shock, it can now be used as exclusion criteria for not ordering crystalloid fluids. Very interesting. So I also like to take a moment to look at something that's a little off topic, but to fluid responsiveness, but it's something I want to bring up. There's some changes to the SEP 1 that's coming next year. So this program from CMS is currently in the inpatient quality reporting system. It's soon to be rolled into the hospital value-based purchasing program. So basically, let me explain what this is first. Let me show you why this is why I'm bringing this up. So the hospital VBP, the value-based purchasing program, is a budget-neutral program funded by reducing participating hospitals' base operating DRG payments each year by about 2%, and then redistributing the entire amount back to hospitals as value-based incentive payments. So basically, they're going to take away some amount of payments, and this is how CMS gets the hospitals to sort of practice the way that they want you to, because it's now tied to reimbursement. So January 1st of 2022, this is a baseline period for collecting data about severe sepsis and septic shock for the management bundle. So unfortunately, this is information that's already existing. We can't have any effect on this, and that's going to be used as our baseline period. The performance starts in a few months. It's going to start on January 1st. This is your performance period. This will be measured against. And then the incentive period will be paid out in 2026. So SEP 1 will now be tied to reimbursement, the day we've all been waiting for. Okay, so let's move on to some fluid management technologies, because I want to go over some information of what's currently available. And I'm going to show you some implementation strategies with this as well. So for the past 100 years, we've been trying to ask the question, will my patient respond to fluids? And for the longest time, we've been using blood pressure. And so yes, blood pressure is something that's a hemodynamic measure. It's something we need to fix. However, it's not a very good predictor of whether patients are responsive to fluid. Now you could say, well, I've given patients volume before and I've watched their blood pressure increase, but I could say equally is that there might be an equal number of patients that we've given volume to that their blood pressure doesn't rise when I give you fluids. So in that scenario, do I give more volume, or do I determine that the volume that I'm giving is not working? Blood pressure is not a very good tool to tell me whether or not volume is working or not. CVP has been out for quite some time too. It's a static measure of pressure in the IVC. When it's in the normal range, it's questionable of how helpful it is. It's also around 50% reliable when it's in that middle range. It could be helpful if it's really high or really low, but it's not really helpful when it's in the middle. PA catheters are really invasive. We're really only using that these days in open heart units, or maybe perhaps the cath lab. So if we're in the ER, if we're doing a rapid response call, for every case that I want to figure out for fluid responsiveness, we're not dropping a PA catheter. So it's a great tool. It's just its usage is not all that wonderful. Echocardiogram. I challenge you, the next time you look at an echo report, go look through all the poetic things the physician has written, And you'll note that typical routine echoes don't perform dynamic assessments. So you can get information about hypokinesis and wall motion and their ejection fraction. But just because their EF is low doesn't mean that they're not fluid responsive where they are. Yes, we have to be more careful with patients with that kind of a history, but it doesn't exclude patients from volume. Something to keep in mind. You could also, as we're learning how to do bedside ultrasound, and we're all getting better with this, we can do IVC collapsibility. Again, you're sort of still looking at the vena cava. It's sort of like, are they plethoric? Are they have too much volume on board? Maybe there's a lot of collapsibility, and it's very obvious that they could require fluid. But again, you're looking at a spot that's telling you if sort of like they're euvolemic or not. That's not really pinpointing whether or not the cardiac muscle can tolerate more additional fluids. It's sort of like a wet or dry assessment. There's different techniques. If you have ways to measure stroke volume variation, this is looking through the thoracic change over time, and then same with pulse pressure variation over time. There's a couple limitations with this. The patient has to be ventilated, no spontaneous breathing, 8 mils per kg tidal volumes, and normal sinus rhythm. So as long as they meet those, these metrics can work well. And then there's newer technologies coming out that are non-invasive, that look directly closer to the heart and looking at stroke volume. And this is when we combine this with passive leg raise and fluid challenging, where we're proactively challenging the heart. Currently, this is the best sensitive and specific way to accurately determine if your patient is fluid responsive or not. So bioreactance is a technology that I just mentioned, so one of the non-invasive technologies. It was recently, this year, compared against pulse contour, which is a different type of way to measure blood pressure and estimate cardiac flow. So these two were put together and looking, and what's interesting is that there was no outcome advantage using a little bit more invasive tech. So using bioreactance as complete non-invasive technology had no difference of time off vasopressors in this case, no change in the amount of fluid that was administered, and this was a paper looking at donors for organ donors, and there was no change with the number of organs per donor. So what about echo? So echo is an excellent diagnostic tool, but it depends on where you're looking. So if we look at the ventricles, and you're a skilled user, and that's great, but there may be some of your other colleagues, or maybe the nursing staff has never trained on this, and if the person who's really good with echo is not around, it can be challenging sometimes to determine responsiveness if this is the only tool that we have. A lot of good, successful practitioners I talk to have multiple ways of assessing volume status, or a reliable way. So if we have, in and of itself, looking at IVC, if this is all we're doing, it can be misleading here. There was a paper put out this year looking actually kind of with a bold statement saying that for the assessment of fluid responsiveness, in and of itself, the IVC diameters are pretty useless. And what he's saying here is that looking at the wet or dry aspect of the IVC is not really helping me determine whether or not the patient could tolerate more fluids. Yes, I can see if they maybe need some. So you need some when their blood pressure is low, urine output's poor. Patients may need volume here too, but can they tolerate? Are they fluid responsive? And that's not what the IVC is really looking at. So there's probably a synergy here for allowing a Starlink mechanism monitor way to determine if patients are fluid responsive combined with ultrasound. So there was a paper looking into this fluid responsiveness aspect in septic patients. This was an RCT that was released in October of 2020. It was one chest publication of the year. It came out during COVID, and not a lot of people actually read into it. So I'd like to share this because I think it's worth a read. It was really well done. It had here are the outcomes over here on the left, and there was what's nice is that they shared a protocol that they used to obtain these outcomes. So this is open access. I encourage you all to go take a look, but it was basically they would do a passive leg raise if the patient was hypotensive, and it would allow the nursing staff to give a certain amount of volume up to about 2 liters through small boluses of 500 to achieve either a response in the instability, fixing, resolving the blood pressure, or if the patient has to go on the vasopressor. It gives them a little bit more bifurcated guidance here. Really interesting. All right, so there's 2 case studies. So I want to kind of put this together to where it kind of makes sense. So I have 2 I want to cover. So here's the first case study I want to kind of cover, just kind of make sense of all this. Say you have a 42-year-old male, paraplegic, large wound to the coccyx, admitted for a septic shock. Through the night, the patient received 6 liters of fluid. They're still on a little bit of low-dose norepi. CVP is 8 to 10, MAP's a little soft, urine output still reserved. So where do we go from here? The patient's still slightly hypotensive. We're at the bedside now, and we have to start making decisions about this patient's care. And I would like a little bit more information. So we have the capability to do a passive leg raise and look at their stroke volume to determine if they're fluid responsive. So SVI, stroke volume index, changed by at least 15.2%. And if we remember, any increase by at least 10% or higher, the number itself is not that important, just 10% or higher, the patient is producing forward flow increase. So this patient is fluid responsive. They can tolerate more fluids, despite the fact that they received 6 liters of unguided fluid overnight. So in this particular case, and this was a real case, the practitioners gave 1 additional liter, and they reassessed. Okay, so it's really important to reassess here. We reassessed the patient, and they now are 6.7%. It sort of makes sense. We give volume, fill them up. There's less available room because they have the additional volume. So the patient's no longer responding as strongly as we'd like, so they've dropped below that 10% mark. However, with that 1 liter of guided fluids, which maybe, me personally, without guidance, 6 liters with the history might have made me nervous. But discovering that they had room for 1 more, gave a liter. Now they're not responsive. However, the levofed was able to be turned off. I'm sorry, the norepinephrine. Here's another interesting case from an emergency department. This was a 68-year-old male, came in with a history of CHF, COPD, CAD, kidney disease, and a pacemaker. His presentation was he was not able to breathe very well. So the initial assessment, he was dyspneic he was placed on BiPAP, his respirations, he was tachypnic, he was hypotensive, he's slightly tachycardic and hypoxic. So where do we go from here? Is the patient presenting with pulmonary problems? Is it presenting with my differential is cardiac? So early on, if we put a device on that allows for a quick assessment of stroke volume, we could do a fluid responsive test, and so that's what we did. Patient did a passive leg raise. It came back 46.2%, and this would indicate the patient is fluid responsive and able to tolerate fluids. So the ED physician wrote an order for 500 mils of normal saline, and the MAP came up. So the MAP was, in the initial, was 55. Now the MAP's 74 after a half a liter. So that's great, it worked. So this patient, because they're on BiPAP, they still don't look that great, got an ICU transfer. So we rolled upstairs, and I followed that patient. And their MAP started to decrease again. So dropped to about 60, and then the nurses upstairs also had this technology. The bioreactance technology, and we did a bolus protocol. So we now gave the patient 250 mils of normal saline rapidly and looked for a rise in that stroke volume again. Is the patient still fluid responsive? Can we use that as an advantage for this MAP of 60? And it turns out they're not. This patient was no longer fluid responsive, it was 3%. But the MAP did go up to about 64. So 3% is not 0, so 3% went up a little bit. We did give the patient volume. It wasn't internal from a passive leg raise this time. So it made their MAP go up slightly. And MAP was 64, the staff was okay with this, and they just left it there. So a couple of notes from this is the patient did not require any vasopressors overnight. Okay. The change from 46% for when we started, when they were in the ER, to the 3% when we were up in the ICU happened with less than a liter of volume. So some of these patients will have a very small treatment window, and this strategy allows us to individually walk them to the exact amount that they can tolerate. Later on that evening, Echo came by and did a scan and confirmed some things that we may already know, but the EF was 25 to 30%, left ventricular systolic function is severely reduced, and global hypokinesis of the LV. But I have a question for you. If this patient, who was diagnosed later the next day with a CT of pneumonia, interesting, if you were back in the ED and you had this information of knowing that they were left ventricular systolic function severely reduced and poor EF, would that have changed the way that you approach this? If you had not known that that patient was fluid responsive, would you have treated this patient a little differently? So what's interesting, the patient never got intubated, the patient never required any vasopressors, and then was eventually discovered to have pneumonia and was treated from there. So when we look at examples of how dynamic measures of fluid responsiveness are used at point of care, I want to share that it's not only in sepsis. So sepsis is very popular for this, but we have a lot of hospitals that we partner with that use for general hypotension, for poor urine output. If I want to give fluids to somebody and improve their urine output, I have to get it through the heart first. And so it's always nice to know if they're responsive to volume first. Active vasopressor drips, some facilities like to have a fluid response assessment done, Q-shift or Q-day, if they're on these drugs. Sometimes you'll discover someone may be fluid responsive. Can we do a trade? Get these patients out of the ICU a little quicker. Very popular in some hospital systems using rapid response calls. Having a non-invasive technology and a non-invasive strategy that's very easily and quickly deployed works very well for rapid response triage. Enhanced recovery after surgery. So if you're not familiar with this is an OR strategy. There's a fluid management portion of that some hospitals take advantage of. Elevated renal biomarkers and subarachnoid hemorrhage. So these are all active ways that fluid management is being used with bioreactants in various levels of hospitals. We are happy to arrange collaboration with these hospitals or just get with us and we'll help you out. So my question to you is what other patient areas may benefit from individualized fluid decisions? So when I think about when do I use a dynamic assessment, when do I really want to know if the patient's responsive or not? I say if you're questioning giving the patient volume, or you have someone with a history of renal cardiac disease or an early phase of shock of sepsis, these are all excellent and well-documented and evidence-based ways to use stroke volume change to guide fluid management, because half of the patients that we take care of that are critically ill will not respond to fluids, or in other words, they will be ineffective and may potentially harm the patient. Fluid responsiveness can change. We give patients volume, they get better. We give patients volume, they get worse. Patients' pathophysiology gets better and worse. There's a lot of things that happen during their course of stay which may or may not make them fluid responsive at a given time. So it's always good to reassess these patients. Sometimes you might get a negative % change. There's some literature that shows that this is pointing to more LV-RV dysfunction. I would advise following up with other diagnostic exams to confirm this. And we know that dosing fluids incorrectly harms patients. So this is a wonderful tool to assess whether or not volume will be effective. So this is the last slide. So the key messages for this. I want to kind of bring 3 points home. So dynamic assessments of fluid responsiveness are safe and easy to perform at the bedside. And it can be done by physicians, it can be done by nurses. Invasive technologies provide no additional outcome benefit in guiding fluid decisions. Non-invasive technologies are becoming really good and really accurate and precise, and we're able to do this. So we don't have to wait for someone to be super sick to verify and justify giving invasive technologies. We can apply this to anyone. With the growing body of literature revealing the benefits of performing dynamic assessments, the unguided administration of fluids to patients with sepsis and hypotension is no longer defendable. And what I mean by this is giving fluids blindly without guidance, especially in sepsis, is becoming harder and harder to defend because there's more literature showing us the benefits of guiding. Okay. So here are my references. I appreciate your time, and thank you very much.